You so much for that warm invitation. It's wonderful to be a part of this conference together. So as mentioned in the intro, I'm Keri Brenner. I am a palliative care doctor at Stanford University. So I'm zooming in from California right now. And I practice palliative care. I'm also a psychiatrist. So all of my academic interest and contributions center on the psychological elements of how patients, families, and providers cope with serious illness. I am going to pull up my slides here, and then we can get started together. Okay, can everyone see okay? Great. So today I'm going to talk about the referral relationship, specifically illuminating the psychological benefits that palliative care offers referring clinicians and teams. And the reason that I'm compelled to share this with you and the U.S.A. Scientific Nursing Conference is that I feel that I can see that there are many elements of cross-pollination between what palliative care is doing behind the scenes and what multidisciplinary nursing is also doing behind the scenes. I have no disclosures to report for this presentation. I just want to start with us exploring if we've ever experienced some of these thoughts in our practice. I think the team needs us more than the patient themselves. I feel like I've been spending more time discussing this case with other nurses and the staff than even at the bedside of the patient. I'm using a lot of my skills debriefing and processing with other clinicians, sometimes even more than the patient and the family. There are some cases that are so complex that we find ourselves doing even more work behind the scenes with other nursing staff, other medical staff, the consultants, than sometimes at the bedside of the patient themselves. And this is something that's very under-recognized and underwritten about throughout all of healthcare. And so I ended up publishing a paper in the Journal of Palliative Medicine that really illuminates the psychological elements of this behind the scenes work that nursing and palliative care is doing throughout healthcare. So today we're going to explore the way that palliative care and multidisciplinary nursing are benefiting clinicians beyond our direct patient encounters. The objectives of this talk are to highlight relevant background on the psychological elements of palliative care, to describe those psychological elements and the way that they offer referring clinicians and teams in a more enrichment of their patient care process. And we created an acronym called CARES, and I'll march through that CARES acronym as a way for us to have a scaffolding to remember these psychological elements of what we do. I'm going to illustrate some practical ways to bolster the psychological elements that palliative care benefits referring clinicians, and to talk about some of the overlap that also nursing provides. There are many scholars, clinicians, and disciplines that have laid the foundation for this work. So I received a grant through the Harvard Radcliffe Institute for Advanced Study. And in 2019, I gathered about 23 interdisciplinary experts to Harvard's campus: nurses, social workers, psychologists, palliative care clinicians, oncologists. And together, we created a transdisciplinary conversation about what are the psychological elements of what we're doing behind the scenes within our work. That conference in 2019 ended up catalyzing an 8-article series in the Journal of Palliative Medicine. That series was published in 2021 and 2022. There are numerous psychological elements of palliative care. This is just to provide an overview of a handful of them. Things like countertransference, transference, attachment styles, the way that patients cope. Today, I'm going to zoom in and focus on mostly the holding environment. And I'll explain what the holding environment is in a little bit. So oftentimes when we think about our work, we're often thinking about how do providers like a palliative care clinician and nurses and any consultant or primary team interact directly with the patient and family. And that's often what we write about and what we study. The reality is, in our day-to-day clinical work, It's more of a triadic relationship rather than a dyad. And when I say that, I mean, there's not simply just what we as providers and clinicians are offering the patient and family, but there's also this other element of the way that we as providers are interacting with other providers, other clinicians, other medical staff and nursing, and the way that those interactions happen and can elevate and enrich patient and family care and bolster that care and be synergistic to our work. So palliative care provides various ways for these different teams and clinicians to process cases. It's not simply informational. It's also emotional and relational. And I know that there's been a lot of talks today that have provided a lot of illumination on this, the way that we emotionally connect with others and the way that we relate interpersonally to others. Often this term called holding space is used, and I even heard that a few times throughout the conference. I want to just highlight what holding space, where that term comes from, the etymology of that term. So holding space is from a concept of a psychoanalyst named Donald Winnicott. Donald Winnicott was a pediatrician and psychoanalyst from the mid-20th century. He was from Britain. And what he did was he noticed something called the holding environment. And when he talked about the holding environment, he noticed the way that a mother, a caregiver, a paternal figure coddled and cuddled and created a secure, trusting environment for an infant. And that secure, trusting environment would provide a sense of stability and groundedness when an infant would feel unraveled or be crying. And that infant was then able to internalize those experiences of security and trust, to interject them in a way that allowed them to eventually integrate, process, and eventually, as they got older, verbalize, reflect, explore, and find greater meaning, to internalize that stability, that groundedness, that sense of security and trust within their own inner world, to carry forth with them as they entered into the world developmentally. Now, the reason why this is relevant within our work is that we're doing this all the time with our patients and families and with other clinicians. We're holding space. We're creating environments of security and trust to really say in a non-judgmental way, I am present to you amidst any extreme emotions. I am here to reflect and process what otherwise would be ineffable with you. The way that we do this is through this CARES acronym that just essentially illuminates all the dimensions of this type of work. So the holding environment is, the C is for changing the dynamic. The A in CARES is for accompanying the other clinicians. The R is to recognize challenges. The E is establishing expectations. And the S is sharing a second look with other clinicians. And I'm going to really try to give small micro vignettes of cases of the way that this plays out in clinical work. First, the C in CARES, changing the dynamic. I'm going to just highlight, this is a story that happened to me about a year ago. I was called by an oncologist who said, Keri, she said, I really need your help with this meeting. I have a 28-year-old woman who has metastatic sarcoma. And I have to meet with the patient and her family to talk about the fact that there's no more treatment options to be offered. And I need to tell them that it's time for hospice. Can you accompany me with that meeting? Can you be present with me in that meeting? So we did this family meeting. And this was a family meeting where, interestingly, I actually said very little. This oncologist just took the lead. She said that what needed to be said. She said that the disease, unfortunately, has spread, that she was recommending hospice, that there were no more treatment options. And after the meeting, I said to the oncologist, I said, you did a remarkable job. I just sort of sat there a little bit as a fly on the wall while you really took the lead. Why did you need me in the room? And she said, Keri, she said, I needed you there to change the dynamic. I've been seeing this patient and her parents for a couple years now. Reflexively, I just keep offering more and more chemo. And it's been so hard for me to say what actually needed to be said. And that's the fact that this is a terminal, incurable illness. And having you there held me accountable and allowed this dynamic to pivot and to open up a greater space in the conversation to the reality of what was before us with the illness. So it allowed me to see, this oncologist allowed me to see the way that we can change the dynamic of a case simply by our presence alone. And I see nursing doing this as well. When we sit with a family visit, we are both supporting those clinicians as they're sharing serious news. Our presence alone holds people accountable to the truth of the illness. We create more expansive conversations by saying we're not just going to be in this repetitive reflexive dynamic, but let's open up a new space for a different kind of conversation that we can pivot to. It allows us to then explore hopes, worries, and fears with patients and families more, and to support them in a way of non-abandonment. So the oncologist also said to me, Keri, by having palliative care there, having that extra support, it shows that even with no more treatment options to be offered, this patient and family will not be abandoned. There will still be clinicians supporting them along the way. The A of CARES, so that's the next step in the acronym. The A stands for accompanying the clinician. When I talk about accompanying the clinician, oftentimes you hear oncologists, cardiologists, critical care doctors saying that they feel in the deep. They sometimes feel totally alone as they face the intensity of these demanding cases. So palliative care and also nursing provides ways of truly accompanying the clinician. And I remember I was in the cardiovascular ICU. This was a few weeks ago, and it was a 50-year-old man who had survived a heart transplant, but had multiple serious medical setbacks after the transplant and was not going to survive the hospitalization. The transplant surgeon was absolutely overwhelmed by the case because the transplant had actually gone successfully, but the sequelae, all of these repetitive setbacks, had really created a challenging situation for this patient where he wasn't going to survive. And I said, let's do this together. Let's watch, these cases cannot be managed alone. Let's create frequent points of connection so I can be with you in this challenging case. So the way that we accompany the clinicians and the way that I did with this cardiovascular attending was to process the case through a different lens. We debriefed the meetings together offline. We shared the emotional burden of the case. I decided to stick with that case through the very end until the patient ended up passing away. So he felt a sense of accompaniment and a longitudinal presence, that it wasn't going to be a lot of pass-offs with different providers. I said to that attending, look, you can page me if needed. You can message me. My clinical workroom is right over here, a couple floors away. Just stop by anytime if you want to talk in person and chat about the case. So I was really accompanying the transplant attending in the cardiovascular unit just as much as I was with the patient and family. The R of CARE. So the R stands for recognizing challenges. There's so much vicarious trauma that can happen within our healthcare system. The system is not built to metabolize a lot of these complex and challenging cases. Palliative care and also nursing shows a multidisciplinary approach to recognizing the challenges of these challenging cases, to normalize it, to validate it, and to create a mutual recognition of the unseen burdens as we carry these cases. I'm thinking about a case from a couple years ago. There was a 70-year-old man with colon cancer who had this wild history of really suffering from substance abuse, chaotic relationships in his life, had some elements of a personality disorder. He kept calling the oncology clinic multiple times a day, was losing his medications, running out of prescriptions early, messaging other providers in a demanding way, and yet his time was limited to short months. So this really, really called forth an interdisciplinary, a transdisciplinary approach to support this patient and to recognize the behind the scenes burden that other professionals were carrying as they were caring for him. To validate with other providers how tough this case was, to normalize the feelings that we experienced with some of these tough cases, that when he was reaching out, demanding and messaging, that of course there's going to be feelings of helplessness or anger or frustration with a case like this. To provide pre-meet so we could all be on the same page and have a unified vision and a unified message for how we were going to care for him. To recognize the unseen difficulties of the case and to protect people from the personalizing the inevitable losses and the inevitable limitations of situations of a man such as this. So that interprofessional team is an essential model and resource, us relying on our spiritual care chaplains, our social workers, any psychologists that we might have available, the nursing staff, our advanced practice nurses. So together as a full team, we can support one another as we're supporting this patient. I next want to highlight the E of CARES. So the E stands for establishing expectations. And I'll always remember a case that happened when I was a fellow at Mass General Hospital. It was a 30-year-old man who had had gastric cancer and was declining very, very rapidly. There had been multiple family meetings and goals of care conversations, and the patient and the parents were all absolutely adamant that they wanted him to remain full code and receive the highest level of care in all circumstances, including going to the intensive care unit. As he was decompensating, one of the oncologists was just felt hopeless about the case, felt very despondent and demoralized. How could this be, after so much care over so many months, that he would still be whisked away to the ICU to be coded? And I remember our team sitting down with the oncologist and saying, this is a case of harm reduction. This is a patient and family that very clearly, even knowing all of the potential outcomes and potential harms physically to remaining full code, still needed that for their own coping, to know that there was no stone left unturned and they had tried everything possible to receive the best care that they imagined to be possible. It was culturally concordant care in a way. And 5 years later, this same oncologist, I met with her at a conference and she said, Keri, she said, thank you so much for simply validating the fact that it was okay for this patient to go to the intensive care unit and to die in the intensive care unit. Because otherwise I felt completely demoralized, like I had failed as his provider. And yet hearing from a palliative care team that this was one of these anomalous cases where in this culturally concordant way, this is what the patient and the family needed that actually aligned most with their values and would actually help them with respect to their bereavement, perhaps diminish some of the augmenting factors for complex grief. These are the things that I needed to be able to carry myself forward and to see the next patient down the road and to not feel completely despondent about the case. And that oncologist is today a phenomenal person, an luminary in the field. And to see that behind the scenes, us establishing expectations, saying this is a harm reduction model, this is a best case scenario where we've tried our best and the patient and family are doing their best, and that's okay. That allows us to maintain resilience and sustainability within our work. So when we establish expectations, we draw upon the unique formulation of the patient and their cultural circumstances. We establish what's possible for the patient. We maintain clinical competence even in the face of serious illness, and we allow other providers to do so as well, to still know that they are good enough with their work. And when I say good enough, I'm talking even about that Winnicottian concept of how do we be the good enough provider where we're offering all that we have in a psychosocial, spiritual, concordant way with the patient's needs, and to release other clinicians of this impossible burden of perfection, and to allow that good enough concept to carry us forth to continue to do our work in sustainable years. The S of care is to share a second look. So primary teams are often called upon to manage the day-to-day details of patients' care. But palliative care and multidisciplinary nursing, our presence can actually offer a more expansive second look on a patient's needs. Think of the number of times that we as palliative care providers or we as nursing staff say, hey, can we just take a step back here? Can we just look at that 30,000-foot view, that big picture? What are we doing with this patient? Can we just step back from the day-to-day routine and think about what's most likely happening here? What's the best case scenario? What's the worst case scenario? What's the most likely scenario for what we're offering? These are the ways that palliative care can share a second look, and the ways that nursing staff shares a second look, We re-examine the patient's medical and psychosocial realities to offer greater insights on the prognosis and recommendations. We ensure a careful consideration of high-stakes recommendations and decisions, and we offer an opportunity to step back and look at that big picture. And this also mitigates personal bias within practice to say, let's together talk about what's really happening within this case from the big picture. And it allows us to get unstuck from those day-to-day details and routines when we're sometimes just so in the weeds that we can't look at the forest or so in the trees. So this is the CARES model that shows the psychological benefits that palliative care can offer referring clinicians. And it's exciting to present here with you today because these are also so many of the ways that multidisciplinary nursing offers to referring clinicians and medical staff. We first help change the dynamic of the way that we're interacting with patients and families. We change those conversations to be more expansive and to pivot when needed. The A is to accompany other clinicians, to allow other clinicians to know that they are being supported longitudinally throughout cases. The R is to recognize challenges, that behind the scenes validation and normalization of the whole medley and spectrum of the way that we respond and interact with patients and the variety of vacillating feelings that we experience with patients. The E is to establish expectations. That sometimes harm reduction model is saying this might be the good enough or the best case scenario for this case or the most likely outcome, and to allow us to be released from that impossible burden of perfection within our work. And the S is to share a second look. We are that second set of eyes that allows other clinicians to take a step back and to think about that big picture of what we're doing and where this case is heading and how we can offer the greatest support to our patients and families. So the practical ways that we all do this within our work in this multidisciplinary way is to offer joint visits, to debrief challenging cases together, to say, hey, what happened in that interaction or that family meeting? What do we think is really going on beneath the surface? To demonstrate our interprofessional framework, the value of chaplaincy, the value of social workers, the value of other nursing care, of advanced practice providers, to provide ways to be accessible and in proximity to patients, to share those longitudinal cases together and the burden of decisions together. So this can create beneficial ripple effects throughout the entire healthcare system where we do this just with one patient or one day or on one unit. It can really transform the way that we're engaging with the entire medical system. These are a few references that I'm happy to share and that are in the slides that you'll receive that both allude to some of the intersectional space of where psychoanalysis and psychotherapy really interacts with palliative care, end-of-life care, and multidisciplinary frameworks together. So thank you so much for this opportunity to present. This is my email. Please feel free to reach out to me if you'd like to really debrief anything together. I would love your feedback and I'm open for questions.